Thank you, Dr. Neglia. So I'm very happy to have our two speakers that we have today. So we first have Dr. Sarah Lim, who's an infectious disease physician and medical epidemiologist at the Minnesota Department of Health. She works on various infectious diseases of public health in Minnesota, including work on COVID guidance, therapeutics, and MISC. She is a co-author of a very nice article in MMWR on MISC. As well as also looking at hospital-associated infections such as Candida auris, CRE, tuberculosis, and other high-consequence infectious diseases. Secondly, we have Dr. Nick Lehnertz, who is a preventive medicine physician, epidemiologist also at the Minnesota Department of Health. He's recently been working on the MDH MPOX response, including clinical and therapeutic consultations. He also works with our tribal nations to improve equitable care in infectious diseases as part of the response team to the invasive group A strep outbreaks that we're having in lung care facilities, and works to understand belief systems that impact care-seeking behaviors in individuals either with or at risk for HIV, syphilis, and other STIs. Both Nick and Sarah have been valuable partners for the Division of Infectious Disease, and particularly Sarah over the whole period of COVID has been just an incredible partner that I don't know how we would have done without her. So I will now turn it over to them.
Thank you very much, Jill, for that lovely introduction. Good morning, everybody. Thank you very much for inviting Nick and I to come and present. So when Jill asked Nick and I to come and talk about some of the work that MDH does, and we were talking about what we could potentially present, we thought that it would be fun to talk about and describe some of the work that MDH does in relation to infectious diseases, and particularly how we approach investigating infectious disease outbreaks. Not everybody is probably familiar with the kind of work that we do on outbreaks, especially if you've never been involved with working with us on one before. And depending on the type of outbreak, sometimes our investigations are very different in their acuity and their scope, but they're usually based on the same type of public health principles, including working with frontline clinicians like yourselves, which is really key. So what we're going to do for this, this next hour is give you, first of all, a very quick sort of bird's eye view of MDH and MDH infectious diseases in particular, and then describe how we've approached the MDH response to two very different types of public health issues. Here we go. Neither of us have any disclosures. So our learning objectives are here. So the two outbreaks that we're going to talk about are novel pediatric hepatitis of unknown etiology from 2022-2023, and then the epidemiology and the MDH response to congenital syphilis outbreaks in Minnesota. So what does MDH do? We really do a lot. It's really almost too much to summarize on a single slide, but I gave it a try. Of course, we're responsible for infectious disease surveillance and investigation, and that's mostly what Nick and I are involved in day to day. But MDH is also responsible for things like food and water safety, healthcare quality, regulation, including locations like long-term care facilities. MDH provides nutrition and vaccination programs like the Women and Children Nutrition Program and Vaccines for Children. And MDH also does a lot of emergency preparedness and healthcare preparedness, collaborating with healthcare systems and federal agencies like HHS and ASPR. And we also do a ton of community outreach and education. We collect and we analyze data of all kinds. We conduct research, often in collaboration with other state health agencies and other federal agencies, again, like CDC. And we educate students and other healthcare professionals in public health to ensure that we have a robust public health workforce for the future. So this is a very busy slide, I know, but this is just to give you an idea of how MDH is structured. So this is on our website. It's not always perfectly up to date, but it gives you a good idea of the different divisions in MDH and what they do. So MDH is led by our new commissioner, Dr. Brooke Cunningham, who is an MD, who was actually an assistant professor at the University of Minnesota before she joined MDH in 2022, and then succeeded Jan Malcolm, our previous commissioner, earlier this year. MDH is divided up into different bureaus, and their names are not always really intuitive in terms of describing what they do. So Nick and I are in what's called the Health Protection Bureau, and we are in what we have called our State Epidemiologist Unit. So we work directly with our State Epi and Medical Director, Dr. Ruth Linfield, and we really provide clinical consultation to all the other divisions in MDH as needed, but we work probably most often with the Infectious Disease Epidemiology Prevention and Control Division, IDEPC, which oversees, really everything that you can imagine when you think of infectious diseases like STDs or TB, vaccine preventable diseases, hospital-associated infections, and so on. The Health Protection Bureau also has the Environmental Health Division, which oversees things like drinking water safety, food services, and the like. And then it also houses our terrific public health lab. Then the Health Improvement Bureau deals with child and family health. It houses the Chronic Disease Division. There's actually a group there that are working on long COVID in collaboration with IDEPC and community health. And then we have a Health Equity Bureau, which is relatively newer, and it encompasses the Center for Health Equity, the Diversity, Equity, and Inclusion Division, and the Office of American Indian Health. Then our Health Systems Bureau really deals with healthcare systems in general, so hospitals, primary care practices, including the Health Regulation Division, which regulates long-term care facilities and other things like that. And then we have Health Operations Bureau, which is really our internal management, so as things like HR, IT. We have a COVID transitional bureau that was actually stood up to manage the various pieces that went into our COVID response, like testing, data, communications. That has actually now been unwound as of just last month, as the pandemic has, or the public health emergency has sort of come to a close. And now its various sections have been moved into other bureaus, including moving our emergency preparedness and response division over into health operations. So taking a closer look at infectious diseases in particular, this is our state list of reportable diseases, which again is available on our website. And you can actually download this as a poster if you like it. It's updated periodically with additions of new pathogens or new diseases as needed. It's actually going through an update at the moment. The general criteria for what is included as a reportable disease are listed here, and it's sort of what you would expect. We want to conduct surveillance on diseases that cause significant morbidity and mortality, those that are new or have been previously undescribed, those that are passed person to person or transmitted from the environment to a person, and those that can cause significant financial impact to individuals or the economy. And then we have diseases divided up into those infections that are reportable immediately by telephone. So those are types of things that would have immediate public health significance, like meningitis or rabies or polio. Then we have those that are reportable within 1 working day, which are still important, but a little bit less urgent. And that's a much longer list of many, many different types of infections, from amoebiasis to zoster. Then we have sentinel surveillance, which we conduct on things like severe Staph aureus and non-tuberculous mycobacteria. And the difference between that and population surveillance is that for sentinel surveillance, we're not trying to count every case in the state. Instead, we have specific healthcare sites or specific regions that track case numbers and give us information about epidemiological trends. You can do a little bit of a deeper dive into some of those cases in sentinel surveillance. Generally, our reporting is from clinical laboratories. Clinicians can report as well. So if you're not sure whether or not something has been reported to us, you can just pick up the phone and give us a call. And when should you call us in general? I mean, you can really call us anytime you want to. If you ever have questions, there's always somebody available that can answer. There are a few situations, though, where we really do want you to call. And really, the main one is what I have underlined here at the top. It's anything that seems odd, anything that's unusual, an unexpected bug, an unexpected exposure. You know, we don't really have a good definition for this other than your clinical sense of, you know, oh, this is weird. This doesn't seem right. And Nick and I have had all sorts of different calls from different providers with just weird cases. You know, we've had, just in the last couple of months, we've had cases of Mycobacterium abscessus after cosmetic surgery, concerns about patients with fungal meningitis after medical procedures in Mexico, drug-resistant tinea recently imported from overseas. I mean, there's a whole mix. And so anything that seems sort of funny, you know, please do give us a call. If you ever see a cluster of cases, and it doesn't necessarily have to have an obvious link, but it seems like it's related in some way, do let us know. That could be an outbreak that we should be investigating. Anything that might be suspected or related to bioterrorism. And, you know, the best example of this is the anthrax attacks back in 2001, where the first indication that something was wrong was the index case that was hospitalized with what turned out to be CNS infection with anthrax. And then anything that is travel associated, you know, particularly if you have a returning traveler who's severely ill and you're worried about something like a viral hemorrhagic fever or drug-resistant malaria, you know, we can liaise with CDC very quickly to see if there's an alert going on for a particular country or a particular region, or even connect with health departments in other states to see if there may be something going on in their locality. And then anything that seems like it's an environmental exposure, so food or water, animals, anything like that. The number here is for the IDEPC division, and you can always reach someone 24/7. There are epidemiologists on call. So you can always get in touch with someone. And then just as a reminder, HIPAA does allow you to tell us about a patient and share their identifying information and their medical records if it pertains to a reportable disease. You don't have to get their consent to do that. It's obviously good practice to let a patient know that you'll be contacting us, but especially if there's a time crunch and it's urgent, you don't have to. So I'm going to move into talking about the first of the two outbreak investigations that we're going to describe, and we're going to talk about pediatric hepatitis from last year. So we'll start with a case. This was a patient that was managed at the University of Minnesota, a 2-year-old girl who presented with 5 days of pale stools, dark urine, jaundice, loss of appetite, and irritability. Her past medical history was notable for neonatal jaundice that had been treated with prolonged outpatient phototherapy. Her family history was notable for a distant cousin that had required a liver transplant for unknown reasons. She was not on any regular medication, but on presentation was on day 4 of a course of oral amoxicillin for otitis media. She had no other notable exposures, including no recent travel history and no exposure to other medications like over-the-counter medications or supplements. On exam, her vital signs were unremarkable. She was afebrile. She appeared jaundiced and had scleral icterus. She had firm hepatomegaly and a fine maculopapular rash on her trunk and extremities. And her labs were notable for really abnormal transaminases with an AST and ALT level, both in the thousands, an elevated alkaline phosphatase and an elevated bilirubin and an elevated INR. So she was admitted with a diagnosis of acute liver failure, and she had a very extensive diagnostic workup. And I haven't included everything here. She was obviously worked up for metabolic and autoimmune etiologies for hepatitis, but really the sense was that she more than likely had some sort of infectious etiology, and so various types of testing was done, and she had a liver biopsy. So here are some of the results from her workup. Her testing for typical viral hepatitis was negative. Her testing for SARS-CoV-2 was not concerning for acute infection. Her EBV DNA was detectable in blood, but testing was more consistent with past infection and low-level reactivation. Her CMV, IgM, and DNA was negative. Her adenovirus PCR on whole blood was positive. I think her actual level was something like 21,000 copies per ml when it should be less than 1. Her liver biopsy is shown here, and it showed diffuse hepatocellular swelling with lymphocytic and neutrophilic inflammation, but immunostaining of liver tissue was negative for both adenovirus and CMV. And the child ultimately underwent transplant on hospital day 10, and she was ultimately discharged. So this case was, or is, part of a group of cases of hepatitis of unknown etiology that were reported beginning in 2022 and were investigated both here in the US and in other countries. It started in early April with a report from the UK of an unusual increase in incidence of cases of severe acute pediatric hepatitis. They identified 74 cases in total over the past several weeks to a couple of months. Most cases were aged between 2 and 5 years, and there was no obvious etiology for this. Testing for viral hepatitis and other causes of acute hepatitis were all negative. And it's not that unusual, is my understanding, for pediatric hepatitis for the etiology to be unknown even after workup. I think for pediatric acute liver failure, it can be as high as 30%. But the number and the severity of the cases that had been identified, as well as the fairly short time frame, was worrisome, and it prompted this alert in the UK for clinicians to be on the lookout for cases. Then a week later, on April 15th, the Alabama Department of Public Health issued a press release. They had reported a cluster of 9 very similar cases beginning back in October of 2021 of children with varying degrees of hepatitis up to and including liver failure. They had notified CDC at the time and issued a health alert for providers in their state, but at the time there wasn't any indication that this involved populations outside of Alabama. Interestingly, in these patients, all 9 of these patients had been tested for adenovirus, and all were positive on whole blood by PCR testing. They were able to sequence 5, and those 5 were all found to have adenovirus serotype 41. So we'll talk a little bit more about adenovirus in a minute, but just to sort of continue with the timeline, the World Health Organization, at the time that the UK issued their report, they issued what's called a disease outbreak news report around the same time about the 74 cases in the UK. And then by April 23rd, they issued another one that described now a total of 169 cases that had been reported from other countries, including the 9 from Alabama here in the US, up to now 114 cases in the UK, and a smattering of cases from other countries in Europe and Israel. So from the WHO report, this is what was known about those initial cases. First, most of them were young, under 5 years of age, although the age range went up to 16. Approximately 10% of cases had required liver transplantation, and there had been 1 reported death. Generally, they had presented with preceding GI symptoms, though typically they were not febrile, and all had, really like our case, markedly elevated liver enzymes and jaundice. Again, testing for acute viral hepatitis in these cases was negative, and no one had identified any common exposure or travel or toxin or medication, anything like that. Adenovirus testing was being done and had been detected in at least 74 cases, so almost half of those 169 cases in the report. And again, of those that had been able to be sequenced, serotype 41 was being detected. And then, just given the timing of this in mid-2022, a major question was whether or not this could be related to SARS-CoV-2. But while 20 of the cases were positive for SARS-CoV-2, it really wasn't a very high proportion of cases overall, and many of them were actually found to have SARS-CoV-2 and adenovirus co-infection. So the question was, how relevant is this finding of adenovirus, and is it known to cause pediatric hepatitis? Well, there's many different types of adenoviruses, and they typically cause mild and self-limited respiratory illness. They're known to cause outbreaks, especially in very close and crowded settings. There have been reports of outbreaks in dormitories and military barracks. And it can also cause gastroenteritis. Adenovirus 41 usually causes acute gastroenteritis in children, often accompanied by respiratory symptoms, interestingly. And there have been case reports of hepatitis in children caused by adenovirus 41, but typically in immunocompromised children, not in otherwise healthy children. And serotype 41 is not that common in the US based on what we know about adenovirus surveillance. You can see here, it accounted for less than 1% of samples reported to the National Adenovirus Type Reporting System between 2003 and 2016. So then the question was, had something changed recently with circulating adenovirus? And interestingly, in the UK, where at this point the majority of cases have been reported, when they looked at their adenovirus surveillance, it turned out they had actually noted an increase in adenovirus in children, beginning in 2021, following a dip in levels during the COVID pandemic. And particularly, this was occurring in 1 to 4-year-olds, that yellow line there that's peaking. And so far, this seemed to be the group that were most affected by this hepatitis. So really, as this went on, or as this began, there were a number of different hypotheses as to what exactly might be going on. And obviously, the first and the strongest idea was really that somehow this was due to adenovirus serotype 41, perhaps with or without some other type of maybe a cofactor that was resulting in more severe disease, or maybe more significant immunopathology that was resulting in more severe liver disease. And, you know, there was evidence to support this idea. Adenovirus viremia was being detected in a significant number of cases, and the age group was typical for adenovirus. But going against that is that, again, adenovirus wasn't known to be a cause of hepatitis in immunocompetent children. Plus, on examination of liver biopsies from affected children, the pathology that was being seen was not typical of adenovirus, and adenovirus itself was not being detected in liver tissue. So it didn't seem to be that simple of an explanation. And then another question was whether what we were seeing was just an unusually large adenovirus season. So maybe something that was a rare phenomenon that maybe had always occurred under the radar was being unmasked and was being seen more commonly just because there was more cases of adenovirus overall. Maybe the pandemic had resulted in a lack of exposure to adenovirus in young kids because of things like school and daycare closures that had resulted in them being more susceptible. Perhaps this was adenovirus co-infection with another pathogen, or maybe with some other sort of toxic or environmental exposure, maybe some sort of novel variant of adenovirus. And, you know, since COVID-19 had just thrown so many different curveballs at everyone, there was a major question about, was this in some way related to SARS-CoV-2? Was it some sort of complication, maybe some sort of MISC type phenomenon related to past infection, some other new SARS-CoV-2 variant, you know, or maybe this was just some brand new pathogen that had not been identified yet, and the adenovirus was a red herring. So work at MDH on this really began in mid-April after the release of the news reports from Alabama and the WHO on the cases in the UK, and after an all-state epidemiologists call with CSTE, which is the Council of State and Territorial Epidemiologists, to update states about what was known and what was being planned in terms of a multi-state investigation. There's a unit within IDEPC that conducts surveillance for viral hepatitis that were tasked with leading this. So there was meetings between that team, the state epi team, including myself and Dr. Linfield, and our public health lab, to talk about how to approach this. And actually that day was the same day that media questions began to come in. They're always very on top of this and very quick to contact us with questions. So the major goals for the investigation were to figure out how to establish surveillance in Minnesota to detect cases, both prospectively and retrospectively, communicate to the public and to providers about this, talk with CDC about the development of a case definition and setting up an investigation to look more deeply into what might be the etiology of this, and then coordinate with the public health lab and clinical labs and CDC to get samples to CDC for testing. So when we investigate an outbreak, we talk about PUIs, or persons under, or patients under investigation. And the key part of an outbreak investigation is the case definition. And there's always a lot of discussion about exactly what goes into these case definitions. And often it's developed further into a confirmed case, a probable case, a suspect case. In this investigation, though, right at the beginning, there really wasn't enough information yet to be able to make those kinds of distinctions. So this was the case definition that was used by CDC and states to investigate cases. It's the same as the one that was used in the UK. It's important to note this isn't a clinical case definition. So clinical case definitions are used to make diagnoses and determine treatment decisions, whereas surveillance case definitions are just used to look at cases to determine whether or not they're part of a particular outbreak. We did use an age cutoff of 10, but I will note that we cast a very wide net and we didn't rule anything out. So we did look at some cases that were older than 10 that ended up not fitting the case definition. But if we had had a case that seemed like it fit, we would have talked to CDC if they were older than 10 and made a determination about whether to include them. We knew that we would need to identify cases really by having providers report them to us. We talked about whether we could identify cases through our own surveillance. And so one thing that we did look at was looking at children with negative hepatitis B and hepatitis C testing, since those are reportable to MDH. So we could look at those and try to do a little bit more digging to see if they might have been a case, but this is very limited. We just don't have the other pieces of clinical information, so it's not the best way to identify cases like this. And then as we identified a case, the investigation would include, first off, we would send preliminary information to CDC, then do a really comprehensive abstraction of the medical record into a standardized case report form. We would conduct a caregiver interview, again, with standardized questions to look at different types of exposures. And then we would coordinate the lab testing. So for retrospective cases, we would chase down results and see if there were still samples being held that we could obtain and send to the public health lab. Our public health lab could do adenovirus PCR as well as sequencing for subtypes. For prospective cases, we would see it would depend on where the patient was. If the clinical or the reference lab had the capacity to do the testing, they could do that. More likely, though, they would just send samples to us. And then we also coordinated with clinical labs to submit liver tissue specimens to CDC for additional testing. So really, there was a big flurry of activity in the first couple of weeks. And by the end of April, we had done quite a number of things. I think one of the first things we did, if not the first thing that we did, was we held a call with pediatric gastroenterologists and hepatologists to talk to them about this, fill them in on what was known and what was not known, and ask them to identify cases. And so the first few cases we investigated were ones that they identified for us, including ones that they had treated over the past few months. CDC issued a national health alert, and we issued our own health advisory with specific guidance for Minnesota clinicians about how to report cases. And the investigating team were on a ton of calls. There was weekly calls with CDC and CSTE, lots of ad hoc calls if they were needed to discuss anything urgent. CDC developed a case report form for states to use, as well as an exposure questionnaire. We looked at deaths in children under 10 from 2021 onward to see if we could identify any potential cases there. Thankfully, we didn't. And by the end of April, we'd identified 2 PUIs from Minnesota and 1 PUI from South Dakota. That's actually the case that I described earlier that was treated at the U. I just wanted to show you what was included in the case report form for this investigation. It was very extensive. It had a ton of clinical information on each case. And not every outbreak investigation will have one this detailed, but again, this was casting a really wide net for something with an unknown etiology. As we got into May, activity on this stage pretty high. By mid-May, there were 180 PUIs identified by CDC nationally, with the majority of them being positive for adenovirus. Our public health lab sent out what's known as an MLS update, which is just guidance to labs about how to send specimens. And the weekly calls continued, and we continued to look into cases. So we found 3 more Minnesota PUIs and were able to rule out 6 highly suspect cases. There was lots of media interest in this. There usually is when it's anything involving kids. And because this was novel and unexplained, there was lots of questions from the media. So MDH staff did interviews, and our communications group put out a press release to ask parents to be on the watch for signs of hepatitis in their children and to seek medical care immediately if it occurred. I wanted to show you this just to illustrate the other type of surveillance that CDC was doing. So CDC looked at national syndromic surveillance as part of their investigation. And so what this does is it tracks people who present to healthcare facilities with specific syndromes or specific symptoms. And it can act sort of like an early warning system for outbreaks. And it's been used to track infectious issues like MPOX or Zika. It's also used to track non-infectious issues like opioid overdoses. So here, CDC is looking at pediatric ED visits linked with ICD-10 codes for hepatitis of unknown etiology. And what they're doing is modeling the expected weekly count, which is this blue dotted line, and then looking at the actual case count and looking to see if either of those increase over this baseline, the exceedance threshold, which is a statistically significant increase over baseline. And you can see that apart from just this 1 week in mid-June of 2022, all other weeks really did not show that ED visits for pediatric hepatitis of unknown etiology were higher than expected. Then as we got later into the summer, the numbers of cases began to decline. We identified 6 in total. Our last one was June of last year. And after the initial work to identify retrospective cases, new cases being identified were uncommon. Similarly, looking globally, the numbers of cases reported by WHO had declined significantly by the end of July. And by August of 2022, very few cases were being reported to CDC. So by August, CDC actually announced that they would step down their surveillance and would make the investigation a little bit less intensive. They removed the exposure questionnaire interview, and they created a new short form version of the case report form. Then they began to publish what they had found as part of their investigation. So this MMWR is from June of 2022, and CDC looked at trends in 2 things. Acute hepatitis in children and adenovirus testing in children to get a sense of the epidemiological trends for both while the detailed case data was being analyzed. So first, looking at trends for acute hepatitis, the top graph here is overall rates of children being hospitalized for acute hepatitis, and the bottom graph is children receiving transplants. And you can see that despite this cluster of cases, overall, the rates for both really were not appreciably different in late 2021 and early 2022 compared with before the pandemic in 2019. And both of these graphs do cut off in early 2022, but after this came out, CDC subsequently said on their website that they had extended this analysis through to early July of 2022 and continued to see the same trend. And similarly, looking at data on adenovirus from LabCorp, this is children aged 0 to 4 on the left and children aged 5 to 9 on the right. And you can see that there really wasn't a significant increase in adenovirus test positivity, that solid blue line going across both, again, during that time period. So that increase that was seen in the UK was not seen here in the US. Then in July, CDC published their interim analysis of cases to date, which numbered 296. They included the demographic and clinical information in those cases, which I won't go into, but their testing findings was interesting. They did detect adenovirus in 44% of specimens tested. And in patients who they had complete information on, they found a wide range of other viral pathogens as well, including SARS-CoV-2. Adenovirus was by far the commonest. That's the top bar here in the graph. But the question was obviously, with all of these other pathogens detected, do all of these represent just asymptomatic carriage or reactivation during acute illness? Are they unrelated, or is there some virus or maybe combination of viruses being the actual culprit causing disease? And of the liver tissue specimens that were examined by CDC, the findings were non-specific and were not consistent with typical adenovirus hepatitis in immunocompromised children. So it's still, unfortunately, unclear as to what exactly was going on, but there was a series of 3 studies published earlier this year in Nature that has offered a possible explanation for this cluster of cases. So there were 3 independent case control studies published from the US and the UK that found adeno-associated virus 2 in a majority of cases compared to controls. So AAV2 is actually a parvovirus, not an adenovirus. It relies on a helper virus for replication that is most commonly human adenovirus. And it has been considered non-pathogenic in humans, but the authors have proposed that in these cases, this is potentially responsible for hepatitis following transmission as a cofactor with adenovirus 41. It was detected in hepatocytes along with a T-cell infiltrate. So they proposed that it is potentially causing immune-mediated liver disease. They also found an association with a particular HLA allele that suggested there might be a genetic predisposition. And then there has been speculation about whether this is all related to changes in exposure patterns to both AAV2 and adenovirus as an indirect consequence of COVID-19 pandemic interventions. But this is all very, very speculative, and I don't think that we'll ever get a firm answer. So as to where we are now, I looked to see if there had been published data on the overall number of cases worldwide to date. And this article from October of 2022 found just over 1,600 cases published in the literature. I couldn't find any real recent updates from the UK or the WHO. And as of early July of this year, this is where we stand in the US, according to CDC, with 395 PUIs so far. And you can see the incidence has really fallen since mid-2022, though there are still odd cases being reported here and there. So when you look at the timeline of this investigation and think about when the most activity occurred, this was really the sprint. Most of the work really took place during just a few weeks in April and May of 2022 before cases declined, and work on this really slowed down. Before I hand over to Nick, I just want to emphasize for this investigation the key role that clinicians really played. So I want to really note the first cases in Alabama were only brought to CDC's attention when clinical staff at a single pediatric hospital that saw the first 4 or 5 cases put them together and noted that they all had adenovirus. You know, for something novel that's not a reportable disease, something like this, public health is not going to know about it. It will be clinical providers that see it and then alert health departments. Our case identification was all reliant on providers reporting them to us. We didn't have a way to identify them through our own surveillance. And pediatricians were really fantastic with communication. There was one pediatric hepatologist from the U who gave some really nice interviews to the media, explaining what was going on to parents and really reassuring them about this. So I we'll stop here. I will hand over to Nick to continue the discussion on a very different type of outbreak.
Yeah, thank you, Sarah. And let me just get my slides prepared here for you. Yeah, we're gonna be talking about something completely different. All right. Okay, you able to see my screen? I'm assuming so. And so I want to talk about congenital syphilis in Minnesota. And in comparison to what Sarah was talking about, this is not acute. This is not new. This is not unknown. This is something that's been going around for decades, right? And I just want to give a quick review, and I do want to look at the time, and so I want to make sure that we're respectful of everybody's time. But just a real briefly thing, syphilis is an infection with Treponema pallidum, and congenital syphilis is acquired when the mother has the pallidum either present or acquired during pregnancy. Early untreated syphilis in the mother, there's an approximately 80% chance of neonatal infection, and late syphilis in the mother, you have an approximately 25% chance of neonatal infection. This being said, it is imperative to screen the mother of the baby during pregnancy. And the recommendations are that for individuals at risk, we screen in the first trimester, early in the third trimester, and then again at delivery. And the reason why we do this is that we need to treat the mother prior to delivery of the baby in order to prevent sort of the congenital syphilis. And so the likelihood of infection and treatment of the baby, and this is all just review, I'm sure you are familiar with this, is based on several factors, including the mother's syphilis status, and then any treatment that she may have had and the adequacy of that treatment, the presence of clinical laboratory or radiographic evidence of syphilis in the neonate, and the comparison of non-treponemal serological titers between the mother and the baby. One thing to note is that maternal treponemal and non-treponemal IgG antibodies do pass the placenta, which can make interpretation of the baby's serological status difficult to interpret. And so, oops. And so here's our obligatory, so I just wanted to mention, this is why we're concerned about congenital syphilis, as we all know that this can result in miscarriage, stillbirth, or death shortly after birth in up to 40% of those individuals with untreated early syphilis. It's an incredibly damaging infection. For those individuals that survive, we see preterm birth and low birth weight and a wide spectrum of other clinical manifestations. There's hepatosplenomegaly, lymphadenopathy. You get this rash with subsequent desquamination, rhinitis or snuffles. And I won't list them all, but innumerable sort of consequences from neonatal infection. And so again, I'm going to keep talking about it is imperative to screen the mother during pregnancy to ensure adequate treatment prior to delivery. And then here's the clinical pictures. Here you can see the very classic desquaminating rash on both the palms and the soles of the feet. And then of course the picture of the baby that's suffering from snuffles or rhinitis. And again, we can go into that, but I want to talk about what we're doing in this, because again, this is not new. There wasn't a whole lot of media attention placed on this. And I want to talk more about, what's going on and how we respond to this. And so on a national level, syphilis is a reportable disease for all 50 states. It's been reportable since 1944. MDH collects cases from Minnesota and then reports it to CDC. CDC then tracks this and comes out with sort of the statistics regarding both congenital syphilis and syphilis. And the last iteration of surveillance definitions, case definitions, was in 2018, and there's specific case definitions for both syphilis and congenital syphilis. And in summary, this is what we're seeing. What we're seeing, and this is the latest 2021 report from the CDC, is that we're seeing a 74% increase since 2017 in cases of syphilis and a 203% increase since 2017 in cases of congenital syphilis. In the country, there's 2,855 cases of congenital syphilis. And that, to me, is just ridiculous. The other terrible thing that's going on is that we're seeing an incredibly disproportionate impact of cases of both syphilis and congenital syphilis in certain populations. And since 2017, in the last 5 years, we have seen an incredible increase of cases in both the American Indian and the Black African American population. American Indians right now have the highest rates of primary and secondary syphilis in the United States based upon race and ethnicity. You can also see here in that cases of congenital syphilis are going up concomitantly with the cases of primary and secondary syphilis among women of childbearing age 15 to 44 years. As I mentioned before, is in 2021, there's been 2,855 cases. That's a 30% increase from 2020 and a greater than 700% increase since 2012. And so I don't want to spend a whole lot of time on the data, but let's just, and then of course, again, the congenital syphilis rate is most impacted the populations of American Indian and the Black African Americans. And so the point is that congenital syphilis in the last 5 years is just continuing to skyrocket, and especially among women residing in the United States. In the last 10 years, primary and secondary syphilis rates among women have increased over 700%, right? And national congenital syphilis rates have also increased more than 700%. And BIPOC populations have been disproportionately impacted in both syphilis and congenital syphilis. So let's look at Minnesota. Cases in Minnesota, they are reportable to MDH. And then what MDH does is we do this sort of monthly time space analysis that looks at sort of a rolling 12-month period and we compare it to the previous 3 years. And anytime we see a standard deviation change or an increase of 2.5 times, we take a closer look and we talk to like the district epidemiologists and local public health and we confer with the STI unit at the Minnesota Department of Health. And we see, does this meet the sort of the qualifications for an outbreak, right? And so if we look at this and there's a sustained change over a 3-month period, then we start thinking, yeah, there might be an outbreak here. What's going on? What are the reasons for this increase? And over the past several years, we have seen increases in 3 areas. We've seen it in the Twin Cities, we've seen it in Duluth, and then we've seen it in the Bemidji area. And so you can see here in Minnesota, there's not a lot of difference. You can see that the cases are going up both for males and females. You can see here that the primary and secondary syphilis rates, like nationally, are disproportionately impacting both American Indians, seen at the top there, at 89.1 cases per 100,000 people, and also Black African Americans. And I'm going to keep coming back to this theme. Here are female early syphilis cases, which is primary, secondary, and then early non-primary, non-secondary cases. And if you look back at the period of time between 2002 and 2011 or so, on South, we just scuttled around between 2 and 14 cases. And then right around 2012, you can see this sharp increase in cases where we've gone from, like I said, 2 to 14 cases a year. In 2022, we're up to 345. It's a striking graph. And again, disproportionate impact on both American Indian and Black non-Hispanic population in early syphilis cases in females. And again, as you would expect, when we have an increased cases of primary and secondary syphilis in females, we're going to see a concomitant rise in congenital syphilis cases as well. And again, mimicking what we saw with the early syphilis cases in females, you can see a concomitant rise in the number of cases of congenital syphilis. So the blue bars represent the total number of congenital syphilis cases for that year. So you can see right around 2016, we had 7 cases. Going up to 21 in 2019 and back to 19 in 2022. And the gray bars represent the number of cases we're seeing in American Indian women in Minnesota during the same time. And the reason why I point that out is that I just want to remind people that in Minnesota, the American Indian population comprises between 1% and 2% of the total population, and that they make up a significant portion of cases of congenital syphilis. And that has to do with how we respond to this type of outbreak. So here's a question that we were told to put in. Which Minnesota demographic is experiencing the greatest rate increase in primary and secondary syphilis over the past 5 years? And that's just a quick question for you. And I want to be respectful of time because I do want to get to this. But again, it's number 3, women of childbearing age. Their rates have increased more than any other group over the past 5 years. And so the key takeaways are, again, primary and secondary syphilis have been increasing dramatically for both men and women, but especially among females, 267% from 2018 to 2022. BIPOC populations are disproportionately impacted. And primary and secondary syphilis, and especially in women of childbearing age, are increasing at the highest rates, resulting in that concomitant increase in congenital syphilis cases. So what are we doing? Now I'm getting to the point, right? What are we doing? And it's because this has been going on for so long, it almost feels like a slog. We're not getting the news attention. We're not getting, to be blunt, the funding. We're not getting a lot of the it's not novel. Like, people talk about syphilis, people are like, nod their head and like, yep. So we have to take a multi-pronged approach, right? And we have to understand the factors that are impacting congenital syphilis, right? And so some of the things that we're going to do, and there's sort of a 6-pronged approach that we're using, is that we're trying to update the screening recommendations in pregnant individuals. That being said, individuals have to get prenatal care in order to be screened. That's why I put a little asterisk or a little number 1 right there to remind me. We have to have provider education. Syphilis is not just seen, associated with certain groups or this or that. Syphilis is everywhere, and we need to look for it and we need to test for it, right? We need community awareness. We need people to recognize that syphilis transmission is happening, right? There's a lot of community awareness when MPOX hit the ground running, but where is the community awareness about syphilis and syphilis prevention, syphilis screening and treatment? We do look at all the cases of congenital syphilis through the Congenital Syphilis Case Review Board, where we actually look at every individual case and try to figure out what exactly is going on. Every single pregnant individual that's diagnosed with syphilis is followed up with. We follow up with the provider to ensure treatment. And if we cannot, if that person is not treated, we assign that individual to a disease investigator, and they find that person, or they try to find the person and get them into treatment. We will not stop following that person until either they've been adequately treated or they've delivered the baby. And then, of course, we monitor and data gather from the known outbreaks in the 3 regions that I mentioned, the Twin Cities, Duluth, and the Bemidji area. And so the whole point of all of this is we're trying to figure out do there continue to be cases of congenital syphilis, and not only that, but early and primary syphilis in women. That question, why, is the key, right? If we want to stop this. And so number 1, and I'm gonna go through these real quick, we want to increase screening. And so we're thinking about basically making a stronger recommendation, or even contemplating putting it in legislation that women be screened 3 times, and it's all women be screened 3 times, not just those with risk factors, but all women at the first prenatal visit, 28 to 32 weeks, and then at delivery. We did this back in 2016, where we actually, sort of made a strong recommendation that people would be screened 3 times. And it actually did have an impact. Unfortunately, there's not a consistent way to ensure that everyone is getting screened at these 3 time points. And so we updated it again in 2019. And again, we're currently working on possible legislation, thinking about mandating 3 times screening. However, as you would imagine, that does have challenges. And one of the things is that it's an increased burden. We have to make sure that insurance companies and Medicare and Medicaid are going to pay for this. They have to be on board. Low risk individuals will be screened 3 times during pregnancy. Is that a good way to utilize resources? There's a low positive predictive value. We're going to see false positives. And so it's going to be overtreated, and people are going to get anxious about that. And so risk-based screening can lead to stigma, especially among disproportionately impacted populations. And so for all of these factors, we do realize that there are some concerns regarding this approach. And then again, people have to show up to prenatal care in order to get screened. And that's one of the major things that we're seeing as one of the major issues. I hate to go quickly, but I'm going to. The second and third response activities are education and communication. We want to educate the providers. We're creating these sort of syphilis-specific summits for providers that see individuals at elevated risk for syphilis. And then we want to really let the community know that syphilis is out there and they're at risk, and not just people that are historically at risk, but women. And so what we've done is we've gone ahead and made signs and billboards and sort of community outreach in areas where there is this ongoing syphilis transmission. And we've sort of focused on saying, like, stop syphilis. You've got the power. Very focused messaging to especially women and those women that are members of the BIPOC community. And so that's being done. I've mentioned the Congenital Syphilis Case Review Board, where we want to look for an in-depth review of all the congenital syphilis cases. And we're looking for barriers to care. Why, touch points, maybe they went to the emergency room and they weren't tested or at that time, maybe there was a missed opportunity there. Was treatment appropriately given? Like, what are some of the cofactors that are contributing to sort of like lack of prenatal care and things? And so we're gathering all the data and systematically putting it into a REDCap system so we can then analyze it and then start to answer those why questions. Here's the caveat though. It's only as good as the data that's coming in. And unfortunately, most parents of the babies that are born with congenital syphilis are not really willing to talk with us. So a lot of this stuff comes from medical records and interviews with providers and things like that. And so it does get a little bit difficult with that. We like I mentioned before, we follow up with every single pregnant individual that has a diagnosis of syphilis. And if we cannot find them or they do not show up for treatment, we send disease investigations to call them, email them, contact them, get them into a provider for treatment. And we will not stop following them until, like I said, they're either adequately treated or the baby is delivered. And then again, we look at the different outbreak areas and we look at the populations that are being impacted. We have the demographic and geographic information that allows us to see what's going on where and who's being impacted so that we can then hopefully combine with the data we're getting from the Congenital Syphilis Review Board, gather all that stuff together and come up with an appropriate response. And so like I will sort of end with, I think, with this slide. Congenital syphilis is influenced, what we found, by multiple factors. This has been going on for decades, right? And we're seeing this increase in the last 10 years. And it's all the stuff that's way upstream, called, sort of like the determinants of health, like housing instability, substance use, and the fear of the repercussions of that substance use by having the child taken away. We see individuals with mental health issues, engagement in transactional sex, interpersonal violence, lack of access to care, distrust of medical systems, all that stuff. And we need to somehow gather all this, focus it, and come up with appropriate interventions that can eliminate some of these things. Easier said than done. And so with that, I'm going to stop. I got lots more to say, but I'm actually going to stop now and turn it over to Dr. Foster. Thanks.
Thank you, both of you, for a very informative talk. Unfortunately, we don't have time for questions, but I do want to make one comment. Is that we either now or very soon will have the ability in all Fairview hospitals to do the new syphilis total IgG and IgM complex test. And there's a meeting going on right now with a different group of figuring out how we can do the screening in ED for pregnant women so that they don't have to come to, well, they should come to prenatal care, but for the ones that aren't coming to prenatal care. And so we're really excited about that. And if people anywhere in the Fairview system, if you have somebody that you want to get the syphilis test back fairly quickly and be able to respond to, can order this test.
Yeah, that's fantastic. And I know we have done some work and some of the proposed interventions I didn't get to, but one of them is sort of like having these pilots of ED-based screening for individuals that don't utilize, they haven't been utilizing the healthcare system sort of in that, prenatal care, this time. Anytime we can get them, touch them in the system, we need to think about screening. So.
Yeah. Thank you. It's been very informative. And thank you for taking time so early in the morning to join us.
You're very welcome. And Jill, I just wanted to say both Nick and my email addresses are on the slides if those are sent out to attendees afterward. We love hearing from providers. Call us, email us. If you have something unusual, believe me, like those are our favorite calls to get. So our door is always open. We really do want to hear from you.
Yeah, absolutely.
Thank you guys very much.
Thank you.
Yeah, thank you very much.